So today, thanks for inviting me and introducing me. I'll talk more about antiphospholipid syndrome, mainly relating to pregnancy and pregnancy complications. Here are my disclosures. And I think what the biggest disclosure is that in trading and clinical, am a pregnancy thrombosis and pregnancy hematology researcher, and I'm not a complement researcher, but I have really smart collaborators and friends that I call friends to really have this collaborative approach and project, which I'll talk more about and welcome your feedback on. So the objectives of this talk today, first to start off clinically to review antiphospholipid syndrome and obstetric APS, then moving into the pathophysiology and role of complement activation and talk about some of the ongoing research we're starting, and again, welcome feedback and discussion on. So to take a kind of a step back, antiphospholipid syndrome is an autoimmune condition defined by either venous or arterial thrombosis and or pregnancy complications in patients with persistently positive antiphospholipid antibodies. And you'll hear this term obstetric APS. Really, I'm focused on the pregnancy complications relating to APS, and in some literature and some definitions, this may be without thrombosis, but I'll just talk a bit more about the obstetric complications. And really, this diagnosis is based on a consensus criteria, a group of researchers together developed, so has some limitations, but as a starting place. To make a diagnosis of APS, you need at least one clinical criterion of venous, arterial, or small vessel biopsy proven thrombosis, or the obstetric complications, either 3 consecutive early pregnancy losses, 1 or more late pregnancy loss as defined by 10 weeks for the cutoff, or preterm delivery due to placental insufficiency or preeclampsia less than 34 weeks. In addition, having persistently positive either lupus anticoagulant as defined by the ISTH criteria, anticardiolipin or beta-2 glycoprotein with varying cutoffs here. And while this seems like a very clear framework, we have it written down, we can follow the lines on if this patient is or does not have APS. In reality, it's a big mess. This is a rare disorder. The pathophysiology is poorly understood. I'll talk a little bit more about that. As we see, even with the definition, there's heterogeneous clinical presentations. And then to top it all off, there's challenges with actually making the laboratory diagnosis and having standardization across assays and across centers, with our newest oral anticoagulants interfering with some of our testing, the lupus anticoagulant testing. When we're focused more on the pregnancy complications, which I'll talk a little bit more about, there's 2 general categories, although always some overlap. 1 or more kind of placenta-mediated pregnancy complications, and they tend to be late fetal loss, the placental problems of preeclampsia, intrauterine growth restriction, so kind of placental insufficiency leading to growth restriction in utero, and then small for gestational age infants, as well as placental abruption, or this category of recurrent early pregnancy losses. And while there is some mix, there does tend to be these 2 different phenotypes for patients with antiphospholipid antibodies. There is wide variation in the definitions, what cutoffs we use, how do we define each of those terms, making it really challenging for this rare population and rare to be able to compare in the literature makes it quite challenging. In addition to those 2 phenotypes, there are more severe manifestations of pregnancy and APS. A severe form and kind of overlapping or severe form of preeclampsia is called HELP syndrome, characterized clinically by hemolysis elevated liver enzymes and low platelets. And our most severe form that can be triggered with pregnancy is catastrophic APS, which is kind of this disseminated intravascular thrombosis, evidence of 3 or more organs or systems or tissues involved, developing in a very short period of time, and the maternal mortality can be up to 50%. So rare, but very significant when these happen. Also challenging diagnosis sometimes to make. So when we look at the actual data, the clinical data, in a large meta-analysis, all 3 of these antibodies, the lupus anticoagulant and these other 2 anticardiolipin and beta-2 glycoprotein antibodies, were associated with late fetal loss, preeclampsia, and intrauterine growth restriction. However, when you tease out the individual studies, it's a little bit more varied. In a large prospective cohort of patients with APS, those were excluded if they had losses before 12 weeks. They found that the lupus anticoagulant was the strongest predictor of adverse pregnancy outcomes, and that anticardiolipin and beta-2 glycoprotein were not predictive in a multivariate analysis. It was really with the lupus anticoagulant and then sometimes the high anticardiolipin. So really varied depending on the study and which antibodies or which blood tests we're doing. Looking at the more, the newer, not really newer, but less data on beta-2 glycoprotein, that in a nested case control study of women with preeclampsia compared to no preeclampsia, antiphospholipid were tested 6 months after delivery, and that beta-2 glycoprotein antibody was associated with severe early onset preeclampsia compared to the others, which were not. We did a Canadian nested case control study and found that there was no association with a baseline blood sample of beta-2 glycoprotein in women with adverse pregnancy outcomes compared to no adverse pregnancy outcomes, although maybe a signal for high titer, these kind of smaller subgroups of unknown significance. So even within similar study designs and in different groups, we're getting different answers. There's even less, more heterogeneous data and more uncertainty and unclear associations with recurrent pregnancy loss. In a different meta-analysis, when they looked out of 46 articles, 27 had an association with recurrent pregnancy loss and antiphospholipid antibodies. Mostly studied was anticardiolipin. But looking at the definitions, only 4 of those used the revised Sapporo recurrent pregnancy loss definition. And as we can see, pretty varied results on what was significant or not. So really not very far ahead and really muddy picture, especially this with recurrent early pregnancy loss. So what do we do about this? We have, this theory or this potential that there's hypercoagulability and thrombosis forming at the maternal fetal placental interface. We use heparins and low molecular weight heparin in pregnancy to prevent and treat thrombosis. So there has been a big move in many trials looking at giving anticoagulation to prevent placenta-mediated complications and recurrent losses, which really has been our standard of care. So that standard of care of using preventative or prophylactic low molecular weight heparin and aspirin to prevent pregnancy loss are based on 5 trials and 352 women. 3 earlier trials were positive, but the last 2 trials were actually negative trials, randomized trials. And we tried to do a pilot trial in Ottawa to say, this question is still not answered. What's the possibility or feasibility of doing this type of trial now? And it was not feasible due to how rare it was, but also this widespread use and standard of care and patient choice and decision-making in such a high stakes environment. There were many methodological issues I've talked already about the variable definitions of what's a pregnancy loss and what's a positive antibody. One study was not truly randomized. One of the positive studies and one of the negative studies had higher crossover rates of 25%. So a lot of, again, not perfect data that we really base our guidelines on. The most recent of the trials, not including our pilot study, was in women who had 2 or more consecutive pregnancy losses with at least one of an ANA, antiphospholipid antibodies, or inherited thrombophilia. And they looked at the lupus anticoagulant or anticardiolipin antibodies, randomizing to molecular weight heparin prophylaxis, dalteparin and aspirin versus aspirin alone. And in this subgroup, again, these are smaller numbers, in the subgroup of the two arms for antiphospholipid antibodies, the live birth rate was 77 versus 75%. Mostly were those early unclear losses. And I think some strong statements in this paper, this was our last randomized trial, that these findings contribute to a growing body of literature that contests the emerging standard of care. There's insufficient evidence to base recommendations for thromboprophylaxis in pregnancy, which I think is opposite or goes in the face of all of our recommended guidelines for use of low molecular weight heparin and aspirin in this scenario. And despite this widespread use and really standard of care, there still remains in cohort studies 20 to 30% risk of pregnancy loss and up to 50% risk of other placenta-mediated pregnancy complications. So where do we go next? Could we look at something that maybe is not related directly to anticoagulation and more trying to understand the pathophysiology or other targets to improve outcomes? So taking a step back and focusing more on pathogenesis of antiphospholipid antibodies. So you have different proteins, and the beta-2 glycoprotein is like a sushi. It floats in the blood in a sushi form in circulation. And that the domain 5, this kind of a darker domain, will bind to cardiolipin, an anionic phospholipid, and create more of a fish hook. It kind of opens up, and then there can be antibodies that form against the top or domain 1. And other antibodies, there are many other antibodies, including anticardiolipin and others not really discussed today. And with these antibodies, somehow we get this blood clotting or procoagulant activity. And I think that's still a pretty big black box. We also know these antibodies inhibit trophoblastic proliferation needed and maternal decidual invasion needed for successful placentation or of the placenta. So we know these antibodies are important, but when we look at the big black box of how these antibodies lead to that outcome, there is a long list of things that are happening. And again, lots of potential theories and different things that researchers are investigating. I'll focus on some more updates for complement activation, how this could potentially link to the coagulation system activation. So complement, and I'm presenting to complement researchers. So this is just my base knowledge, but it's part of the innate immune system, really complex, many proteins and regulatories making up 3 different pathways with big targets or big things that they do is identify foreign material and damaged self in the body that then can eliminate targets either through cell lysis with the MAC or membrane attack complex or stimulates phagocytosis, as well as promotes other kind of pro-inflammatory and promotes immune responses. And we're learning even more that there are other roles of complement I won't talk about. And it's really interesting when we look at the complement system alongside the coagulation system. There's multiple kind of these pathways and feedback loops of these multiple proteins and proteases. And there's also tight regulation and balance of the two systems, one focused more on inflammation and one focused more on thrombosis. But in reality, there's a lot of crosstalk and a lot of back and forth that we're learning as well. Some proposed mechanisms of complement activation by antiphospholipid antibodies, and Dr. Chaturvedi, who's one of my smart colleagues. So this is a slide from her summarizing some of the literature, but that some immune complexes in APS could bind C1q and activate the classical complement pathway. That beta-2 glycoprotein itself could inhibit complement activation by enhancing C3 and C3b degradation. And then some evidence that it may inhibit the factor H involved in regulation of the complement system. So all potentials and some for further research to be done. What about from the obstetric side? We have seen that placentas of patients with APS have markers primarily of C4D byproduct, a byproduct of the classical pathway activation. This has been in many studies, including summaries in a meta-analysis, and that there is a role of complement in activating especially neutrophils and tissue factor at the level of the placenta to drive and potentiate inflammation. And that angiogenic dysregulation is a key factor for placenta-mediated complications, and that we know from studies in patients with antiphospholipid antibodies, or maybe mice models as well, that this complement triggers TNF alpha and anti-angiogenic factors within the placenta. There have been mice models looking at fetal loss induced by immunoglobulins and antiphospholipid antibodies. And those that are deficient in complement factors, especially C3A and C5A, are resistant to fetal loss. But factor B on the alternative pathway also does seem to play a role. And treating these patients, these mice, with inhibitors of complement activation also leads them to be resistant to the fetal loss. So a clear role for complement, still trying to find that balance and how much each pathway is involved, but definitely a lot of evidence towards the classical pathway in these placental and mice models. From a clinical side, pregnant patients who have antiphospholipid syndrome, primary APS without autoimmune disease, do have low C3 and C4 levels, both pregnant and non-pregnant primary APS patients. And that in a large cohort study, prospective cohort of 487 pregnant women with lupus and/or antibodies, these complement byproduct measures were measured monthly, and then the outcomes, adverse outcomes, were present in 20% of this complication as listed here. And again, slight variations on each of these definitions, but overall that idea of the placental mediated pregnancy complications. In that prospective cohort, the circulating levels of B and the C5b9 were higher than in pregnant controls. And in both, it's kind of lupus and/or antiphospholipid antibodies with the outcome, with the obstetric outcome, without the outcome, and then healthy controls for both byproduct levels. And that this in particularly early 12 to 15 weeks and 16 to 19 weeks gestation in those with antiphospholipid antibodies was associated with adverse outcomes. This is our kind of best level at the level of the byproducts that we're measuring. But they also tested others, both of the, you can see the list here, and they were not associated with adverse outcomes. So Interestingly, that this study had more of an possibly the alternative pathway, whereas our earlier work may be more of the classical pathway. Is there more, and this is going into our research and work from Johns Hopkins in particular, is there a more direct measure of complement activation instead of relying on C3 and C4, these complement byproducts? Is there something more functional that we could study with complement, especially in these patients? So researchers, Robert Brodsky, as well as Shruti Chaturvedi at Johns Hopkins, and many others in their lab developed this specialized test called the modified ham test. This uses a really interesting PNH cell line. So that lacks the pig A or the GPI anchor for CD55 and 59. And so it's very susceptible to cell lysis. And so by adding serum in of patients who may have activated complement compared to a control serum and seeing what happens to those cells, if those cells lyse, as a measure of this functional complement activity. And this was really developed to help differentiate the challenging case of TTP versus atypical HUS, with details of this here on the right, that this was a certain cutoff of 20% was used to differentiate that atypical HUS versus TTP or healthy control group. But could we use this in antiphospholipid antibodies and syndrome where we know that there may be this complement activation happening? And so this was a landmark plenary talk at ASH and landmark study published in Blood from Dr. Chaturvedi and colleagues that showed that there is this increase in functional complement activity in patients with antiphospholipid syndrome compared to those with lupus, and especially in that higher CAPS or catastrophic APS group. And those with more positive antibodies, the triple positivity of anticardiolipin, beta-2 glycoprotein, and lupus anticoagulant also had more functional complement activity compared to somebody who had maybe one of the antibodies positive. And they also found that using serum from APS patients, this induced this C5b9 deposition seen and detected by flow cytometry, which also correlated with cell killing with the modified ham test. And this is just one example of a patient, the normal human serum with EDTA's control, using a Shiga toxin for the positive control, and then the APS patient, kind of the control, the APS patient. And then they also used antibodies or drugs, eculizumab, they use an anti-C5 antibody, and then here, and then also a factor D inhibitor, this ACH4471, to see what could be inhibited. And it was only inhibited by the anti-C5 antibody and not the factor D inhibitor in these patients. So really a bit more from the classical pathway, at least for these patients, which were more thrombosis, not really pregnancy related. They also completed additional germline gene testing in comparison to atypical HUS, which has a high proportion of germline mutations compared to lupus, APS patients, normal patients, and catastrophic APS patients. And it was the catastrophic APS patients in particular that had these novel gene mutations for complement that they discovered. So really proposing from the Johns Hopkins group a multi-hit model for catastrophic APS and for APS. So if you had antibodies that could activate complement, and then you may have an added trigger like pregnancy, infection, surgery, that could then trigger or lead to something like thrombosis. But maybe in the patients who develop catastrophic APS, maybe there's more to it, that there's an added level of having an abnormal mutation in a complement regulatory gene, plus the activated complement and APLs, plus the trigger leading to this life-threatening complication. So that was all for thrombosis related and really interesting data for the modified HAM test, not relating to APS, but in those pregnant women who develop HELP syndrome, so not APS related, but this can develop as part of a severe form of preeclampsia. 62% had a positive modified HAM test compared to healthy controls, similar to that atypical HUS group. And they did not find any difference in complement byproducts between the groups that were tested. And interestingly, they also found a high proportion of rare germline mutations in patients with HELP. So a syndrome, kind of a clinical pathological syndrome that was thought to be only relating to endothelial dysfunction and a lot of inflammation, endothelial dysfunction with preeclampsia. We're learning that maybe, especially for these rare forms, that there are these underlying complement mutations that could really add to the mix. So having that genetic risk factor plus other environmental risk factors that could then trigger something more severe. And they were similar mutations seen as in those with atypical HUS. And one interesting case from Dr. Chaturvedi is that in one pregnancy, a patient with antiphospholipid syndrome who tracked over a couple of blood tests found that there was evidence of that positive modified HAM test, that functional complement activation at least 1 week before everything happened, before she developed HELP syndrome, had elevated liver enzymes, hemolysis, renal failure, needed to get plasmapheresis, have a C-section, get steroids at 24 weeks gestation. So this is really interesting. Can we start to identify things ahead of time, knowing that there is this complement activation that's happening under the surface? So the research that we are doing and just starting in collaboration with Johns Hopkins, that CIHR funded, as well as funding from CanVector, as well as Lupus Canada, is a small cohort of pregnant, although it's rare, so a big cohort of pregnant women with antiphospholipid syndrome as defined by the revised Sapporo criteria, where we expect 1 to 2 eligible patients per site per year, and ideally comparing them to an age and parity match control group, getting those serial samples across pregnancy, similar to the PROMISE study, but really diving a little bit deeper into information, including the modified HAM test, the complement byproducts, as well as the germline genetic mutations. With our primary objective is to see if this complement activation, as detected by the modified HAM test, is associated with development of those placenta-mediated pregnancy complications, the composite outcome of a few different ones, including HELP syndrome and CAPS. And then comparing things like the pregnant women with APS, how do their modified HAM tests compare to a healthy pregnant control group? What happens with complement activation detected by the modified HAM test relating to the byproducts of complement, and other information about coagulation and platelet activation? And then comparing the frequency of germline mutations and complement in these two groups, in pregnant women with APS and healthy controls. I think I'm learning a lot about, I'm a clinical researcher, and I'm learning a lot about the lab logistics and lab SOPs. So thank you for my collaborators and for your patience. And we're looking at other measures thrombin generation, a functional measure, thrombin generation by CAT, other antibodies, including domain 1 beta-2 glycoprotein, looking at TAG, and platelet membrane dynamic imaging with Dr. Agbani, who's in Calgary, and I saw gave a seminar in the fall, at least on the list of speakers. So a lot of this is coordinating where is the blood going and what are the different requirements between, and how can we share samples to really learn more about these highly complicated patients with APS. And just a couple of slides, and then I'll open it up for questions and feedback, is that platelets and how platelets interact with complement, I've been reading, is quite complex. There's some kind of, it helps to balance, others activation. And so I think the opportunity to collaborate and work on very specialized platelet imaging to be able to do this with a Jaffe and Dr. Agbani in Calgary and in the subgroup that will be in Calgary. So just a few samples to really study in high definition images what's happening with the platelets and how they're interacting more in vivo with these different systems of the beta-2 glycoprotein and these different elements of complement. And this specific grant is supported by Lupus Canada. So there are complement-mediated therapies. Eculizumab has been used successfully in patients with catastrophic APS, but only a handful, and these successful case reports, whether that's successful in all cases or not, we don't know. And I think there's been at least one or more for use of eculizumab in pregnancy, but again, very little data, very expensive for these high stakes decisions and patients and with risks, with potential for infections. And so I think further study and getting more information is needed before we move towards therapies like eculizumab or other complement therapies. Dr. Salmon and where Branch is looking, they're looking at using pegylated interferon in pregnancy to improve pregnancy outcomes in pregnant women with APS. So targeting other aspects of that inflammation, complement inflammation, to see about improving pregnancy outcomes. And I think there is a related study looking at HELP syndrome and giving complement therapies. Dr. Cheddareddy could add anything further at the end to see about in those rare serious cases of HELP syndrome using complement therapies as well out of Johns Hopkins. And so our most recent guidelines from the Antiphospholipid Syndrome Task Force, from the APS Action Group, is that complement inhibition may have a role as an adjuvant or main therapy for patients refractory to anticoagulation, but more clinical data is needed first. And so ongoing research is needed. And with that, I'll stop and take questions and any feedback, especially from the complement researchers or really any questions that you may have. Thank you.
Thank you, Leslie. So I'm going to open this up first before I ask all the questions that I have, but we have lots of people who are excited about complement. We have some world experts. We have some former world experts. Even Dana Devine is a former world expert, as a matter of fact, in complement. But we have lots of people here. So you can either send them a chat, but we have a small enough group that you can just unmute and ask away. I can see Ed is unmuted. So do you want to start, Ed?
Oh, sure. I'd love to. Thanks for that. Really informative. I know very little about the clinical aspects that you were discussing. So thanks a lot for joining us today. I was curious about your C4D observations and correlations, and then talking about how it's an indicator of the classical pathway. and then talking about how complement precedes HELP syndrome by at least a week, and wondering about C4D is also an indicator of the lectin pathway. And I'm wondering about whether or not the week before HELP syndrome is evolving, whether any of these correlations might have anything to do with a cold developing in any of these patients. And maybe the lectin pathway is kicking in as a consequence of some other malady.
Yeah, I think that's really interesting. In a lot of the literature, it is really just talking about this classical versus alternative pathway, and they don't really speak a lot to the lectin pathway in this APS group. And I don't know if that's maybe some of the placental findings are earlier, and we don't have that clinical history, but that's really interesting to say maybe there's something else that's triggering what happened around that time, and how could we tease that apart. I think that's a really good point to look into further. Yeah, really. Thank you. And I'll just maybe even introduce Dr. Chaturvedi, who probably knows more about complement than myself in this area. So if there's anything, Shruti, that you'd like to add on top of what I've read or come across, feel free, or others, of course.
Shruti, hi.
Hi, everybody. Thank you, Leslie, for putting me on the spot. I'm not going to pretend to know more than other people on this call, but I think it's a really fascinating point that you bring up about the lectin pathway. So in many of these experiments that Leslie described, we really use alternative pathway blockers and terminal complement pathway blockers to try to tease out whether this was alternative or not. And really, when we find that it's not primarily alternative, we concluded it was probably classical lectin, and perhaps we're assuming that this is mostly classical based on the antigen antibody type of reaction that we presume is happening. But it does make sense that there could be a trigger such as an infection, because in CAPS also there is a trigger that we can identify in up to 80% of cases, which is often infection. That case that Leslie showed was particularly intriguing. That patient did not have an infection, and we were just planning to get serial samples on her and see what happened, but she decompensated 3 days after a sample. So I think we were catching her on the uptick. I don't know if we had tested her 3 days more prior, whether we would have still seen it. But that's something I'm hoping Leslie will be able to answer with her studies, because she's designed them so rigorously.
Thank you very much.
You know, I'd make a comment to that, Shruti, and to Leslie and others, that it highlights the limitations we have really in monitoring and measuring activation of complement via the different pathways. We're really lacking in activation markers for each of the pathways. So you're interfering with it, say in vitro, really, it's after the fact. So you're measuring it in serum, for example. So that's after the event has happened. So you're measuring, you're looking at post-consumption essentially of the triggers. So it's a challenge to come up with a definitive answer what pathway was activated, not to mention all the complexities that we don't understand in terms of bypass all the way down to the terminal pathway. So it's really interesting, and Ed raises that point about lectin pathway. We don't really know, do we?
We've started to add now MASP inhibitors and specific classical pathway inhibitors to try to tease this out. It wasn't done in the first stage of
yeah. I think that's where these complexes, a better understanding of these complexes, circulating complexes, may be ultimately useful, because we don't really have activation fragments coming off. It's not like, thrombin, which has F12 fragment or something like that. Exactly. I would like to ask, it's interesting, from a hematology point of view, if I go back 30 years or something like that, when I was in Toronto and I was actually seeing patients, we were still doing the same clinical studies then with aspirin and prednisone and low molecular weight heparin even. And all those studies have been done, undone, right? And we still have no answers to them. I'm asking, I wonder if we would have done some clinical trials with anti-complement drugs had it not been, quite frankly, for the expense of Alexion's eculizumab, and would we be farther ahead had we had the option of doing it? So in other words, if you had the option, and if it wasn't an expense issue, would you be diving in to do some clinical studies?
Yeah, I think it's really helpful to take that step back and say maybe the anticoagulation isn't the whole answer. At least the earlier studies that were positive really kind of followed the wave of all of the follow-up studies. And now there is a study looking at Plaquenil, the study by Jane Salmon looking at interferon. So starting to look at different things. It does make me a little bit nervous with the lack of information we have, just this information about the byproducts of complement, and then involving and getting these expensive medications for very high stakes and high risk patients. As part of that pilot study, we interviewed and did a qualitative study asking about, how making those decisions, and a lot of women would look to anything for a successful pregnancy after multiple pregnancy losses, after severe outcomes, and really relied and looked to heparins and the injections as kind of that lifeline to say, like, this, I need this to get through my pregnancy, for example, is what one patient said. So I would be nervous to have the different complement drugs, which are very expensive. You have to give in different ways with risk factors. I don't know if we're there yet, but looking at different targets, I think is, yeah, looking at things that are non-anticoagulation maybe is our next step.
I would venture, I would venture to say that taking an anti-complement drug is probably, and maybe not eculizumab, maybe not something that turns off C5b9 formation, but a C5a receptor or antagonist, or even C3 is probably a heck of a lot safer than taking low molecular weight heparin for 6 months, where your bones sort of fall apart. And there's bleeding risks, small but real. I would suggest that that's probably a better option, depending on how those drugs are delivered. We're not there yet, but there are certainly a lot out there coming very rapidly. I think it would be very interesting. Yeah. Others?
Yeah, I got a question.
Oh, sorry, Leslie. No, let Leslie answer to that.
Just to ask that when we do those studies, that it be the randomized trials or it's hard because APS is so rare, but the more data in a trial form, rather than just kind of assuming into practice based on our past. But yes, absolutely.
Okay, so I've got a question for Leslie. Basically, the heparin trials used a very low dose, it's 5,000 units. And heparin actually is a very good anti-complement agent. In fact, that's how it was first described. And with low molecular weight heparin, you're actually going to get 3 times the weight for the same anti-10A activity as standard heparin. I'm not sure that people have really explored all the options of heparin. Cheap, it's available. 5,000 is a homeopathic dose, from my opinion. And I think there's still some mileage there. I know the early studies look very impressive. I'm not up to date on the later ones you've obviously studied. I think the first study was by Williams, I think way back, was quite impressive. Have we lost interest in heparin as an anti-complement? Don't worry about the anticoagulant bit of it, but as an anti-complement.
Yeah, I think that's really interesting that all of the earlier studies, and maybe it was your higher risk group, maybe there's other reasons why it was positive, but they were all with the unfractionated heparin compared to the most recent. I think with the improved safety profile of the low molecular heparin, there's been a shift in clinical care for all patients to get low molecular weight heparin. But it's a good point that maybe that anti-inflammatory, anti-complement, there's that difference, which I don't think we appreciate clinically. Yeah, good point.
Thank you.
I had a couple of questions for you, Leslie. I just really interested in this linkage amongst complement platelets coagulation. I think that there's really something to be pursued there. There's a whole host, as I'm sure you're aware, of interactions between complement proteins and platelets, from direct receptor binding to C1q binding upon platelet activation, just because of the negative surface that gets presented on by the platelet, and that you get this full enhancement of complement activation on the surface of an activated platelet compared to a resting platelet. And so you wonder whether there's a feedback loop that's going on here that just exacerbates the whole problem once it gets kicked off.
Thank you. I'm also, not only am I learning about complement complexities, I'm learning a whole lot about platelets and just it's pretty, I think a lot to learn and a lot to look at, and how they can interact with each other. In that longer list of the pathophysiology, they're all separated, but how are they connected with the different cells? I don't know if Jaffe, if you're still on the line, if you have any comments from a platelet perspective. I'm not sure if he, no, I'm not sure if he still is, but I'll pass that on, and I think further discussions, absolutely.
Yeah, and then my other question, I think, is really was following up on what the two Eds have talked to you about related to the lectin pathway. And if I remember correctly, I think probably 20 or 25 years ago, Bjorn Dahlback had done some very interesting work looking at mannan binding lectin and antiphospholipid antibody syndrome. And so there's a little bit of literature back there, which I don't remember all the details of, but it might be worth taking a look at in this context, because I don't think he was really looking at the pregnancy loss issue as much as he was with patients who were clotting because they had T-cardiolipin antibody on board.
Okay, perfect. Thank you. I will definitely look into that.
Hello?
Oh, I see Gao on the line. Hi, Gao. Nice to see you.
Hey, Ed. Good to see you. Hi, Leslie. How are you?
Good.
I want to thank you and Shruti for doing this important work. I mean, this is really an important area, and I think, very beneficial for patients to have some alternative therapies. I think we're far away from doing anti-complement therapies in pregnancy, just given how difficult it is to do studies in pregnant, patients, let alone the rare patient, population that you're seeking to study. So the question to you is, do you know of any clinical studies that are ongoing? I keep hearing about various planned studies, but with either APS or SLE and anti-complement therapies. I know Alexion was exploring anti-C5 therapy for lupus nephritis, and I don't know if there's anything planned in APS. I thought there was something in the works. Are you familiar with any of those studies?
Maybe just in the wind that maybe there's these potentials, or are we interested? But I haven't heard of anything specifically or anything moving forward from my knowledge. Shruti may have additional. I'm not sure if she's still on the line, but and maybe it is that kind of the CAPS, although it's also very rare, these high risk ones where we are seeing the complement activation, the triple positive patients or the catastrophic APS patients are also the very rare patients. So it is trying to find that population where we may see benefit, but it is common enough that it could be a feasible study. But yeah, I think you're probably more in the loop than I am. Thank you.
Hello?
Yeah, just before you go, Jeff, there was a New England Journal just in mid-February. There was this paper about the ANCA-associated vasculitis using the C5a receptor inhibitor. So it's also relatively rare. I guess it's fairly rare. I don't know relatively to APS, but so there are, there's clinical trials that are happening, but we need it in APS, obviously. Yeah.
Oh.
Who had a question there?
Hi, can you hear me?
We can hear you. We can't see you, but we can hear you.
Yeah, I have an internet problem. This is Jing Feidong. I'm calling from the Bloodwork Northwest and University of Washington, down
We
south
know,
from you.
we know where that is.
I know. So I have this is a really good talk. I have several questions. So number one, do you know whether PE patients will have a high level of antiphospholipid antibodies? Second, would the antiphospholipid profile in APS patient before without pregnancy differ in terms of CL antibodies or beta 2 the antibodies?
I missed your first question. If you could repeat your
Sorry. The
answer.
first question is, do patient with preeclampsia
Okay.
have detectable antiphospholipid antibody? May not be qualified as APS, but they do detect residual. Do you know that?
I don't know in a kind of systematic study, but it is especially in that early onset or severe preeclampsia that can be the first signs of antiphospholipid syndrome. So I think they would be higher, but I don't have a specific numbers to say how many patients or proportion of patients with preeclampsia who have the APL. I think overall it would be low, but you're right, probably some that would be positive and maybe even at those low levels. And there has been some work and that the antibody profiles are fairly stable in a pregnancy over time. Whether I don't know how much the titers themselves change, but whether they're positive or negative do tend to stay the same with whether it's the beta 2 glycoprotein anticardiolipin and which IgM or IgG. So I think that does that we do have data for that. It's a good point that maybe there are times where things could be at low levels or high levels for these types of patients.
So the second question, sorry, I got too many questions because this is a really an interesting topic. So second question is, if you look at the antiphospholipid profiles of patient APS, do you see the profile change? In other words, the antibody titer changes after the patient get pregnant?
I think it's been one or two small studies where they've been similar before and after pregnancy. But in there have been other cohorts, kind of non-pregnant cohorts, and things do still fluctuate that in patients who have lupus anticoagulant positivities, not pregnant, this will, go down in a number of cases and then come back up. So in the lifetime of a patient, I think it does fluctuate. I think it's been just small studies that they do look fairly consistent across a pregnancy. I can try and find that information for you.
Thank you so much. So the last question, sorry. So that CL antibody, essentially, the cardiolipin is unique, right? It's only expressed almost exclusively in the inner membranes of mitochondria. So essentially, in order to expose to antigen as antigen, you have to cross two membranes, plasma membrane and the mitochondrial membrane. So that suggests there is substantial release of mitochondrial material in addition to cardiolipin, right? So given the fact that the surface layer, the syncytial trophoblasts is constantly apoptotic and then they release microparticle, a bunch of things, is there any other mitochondrial markers detect during the pregnancy, either with or without APS?
I don't know that. That's a really good, really interesting question. I'll be following up. I don't know. That's a really thoughtful discussion to think about and how that changes, especially within the trophoblast. I don't know. I will read.
Because that cells don't proliferate, right? They just keep dying. They're being pushed to the surface, exposed to blood, and they just died off. Sorry.
Are there other, before you keep going?
I'm done. I didn't mean to prolong the meeting.
No, don't be
Sorry.
silly. Don't be silly. It's fabulous, fabulous. Are there any other questions from the crowd? It was fantastic discussion.
Yeah, it's really helpful to hear, and definitely from the clinical perspective, all these things to consider or think about as we work together and collaborate from the lab and from the clinical side.
Well, it's a challenging problem and it's much needed research. So it's great to do this. Anybody else? No. Well, you know where to reach her, okay? Leslie is University of Calgary. I'm sure you can find her. All right. So if you have any other questions or suggestions or opportunities to collaborate, certainly contact her.